Hi, this is Michael Altos, and we are recording part 2 of antimicrobial agents. The first classification of antibiotics that we'll discuss are those that affect the cell wall or the cell membrane. By interfering with the synthesis of the cell wall, these drugs kill cells, and they are bactericidal. So they work best against gram-positive bacteria, which only have that single lipid bilayer. Although they will have some coverage against anaerobic and Pseudomonas drugs, especially the broad-spectrum penicillins, which we will discuss in just a few moments. Penicillin is sort of the classic example of a beta-lactam. Amoxicillin, nafcillin, anything that ends in cillin is a derivative of penicillin. They're called beta-lactams because of this OCN structure here. This is the beta-lactam ring, this four-membered ring, attached to the five-membered ring. And we'll see later, you can also have the beta-lactam with a six-membered ring. This is what a penicillin looks like. And by changing this side chain over here, we get different kinds of penicillins. Resistance is when bacteria are no longer affected by an antibiotic, and bacteria become resistant to penicillins in a number of ways. They may generate substances called beta-lactamases, which break the beta-lactam ring. Bacteria may modify certain penicillin-binding proteins that exist inside of them, and then the penicillin will no longer work. Or they may alter their channels in such a way that penicillins are no longer taken up into the bacteria, or that they are more rapidly pumped out of the bacteria. And we have come up with ways to overcome resistance. We have developed beta-lactamase inhibitors like sulbactam, tazobactam, and clavulanic acid. These are substances that inhibit the beta-lactam from breaking down the beta-lactam ring. And so these are given together with a penicillin drug. And you should be aware of what these three things are because we are exposed to them a lot in the perioperative period. So unicin, zosyn, and augmentin each are a penicillin with a beta-lactamase inhibitor. Common adverse reaction to any penicillin include hypersensitivity like anaphylaxis, rash, or fever. People can have a delayed reaction like a rash or a fever. And people can have GI symptoms, including GI upset, nausea, vomiting, and risk of infection with Clostridium difficile, which is C. diff. The other beta-lactam that we see a lot of are the cephalosporins. Cephalosporins come in many different generations, and I've given just examples of each, but there are dozens of beta-lactams out there. Cefazolin is our most common first generation, cefuroxime and cefoxitin are common second generation, ceftriaxone is a third generation, and cefepime is a fourth generation. There's even some fifth generation cephalosporins out there now. These are a lot like penicillins, perhaps a little bit more stable, and because they're primarily gram-positive, especially the first generation cephalosporins, they provide excellent coverage of skin flora and have become the antibiotic of choice for many different kinds of surgeries, including cardiovascular, orthopedic, biliary, pelvic, and intra-abdominal surgery. As the risk of gram-negative infection increases with some of these surgeries that we've just described, we may choose a second, third, or fourth generation cephalosporin, which has more resistance to beta-lactamases and has better penetration of the blood-brain barrier, as well as the gram-negative coverage. Resistance to cephalosporins is a lot like that with penicillins, and the adverse reactions are similar as well, although true anaphylaxis to cephalosporins is somewhat rare, but people can be allergic to them. By far the most common cephalosporin we see in the operating room is cefazolin, also called Ancef or Kefzol. Usually it's dosed a gram every 3 to 4 hours, with increased dosing for patients who are over 80 kilograms, and some people are even using 3 grams now when the weight is greater than 120 kilograms or the BMI is greater than 40. In children, we dose 25 milligrams per kilogram, up to a maximum dose of, now it's probably 2 gram total. A lot of people know that there is some sort of cross-reactivity between penicillin and cephalosporin allergy. And this is controversial Because first of all, a lot of penicillin allergies aren't really allergies at all. There's some sort of other adverse reaction. In addition, patients who have penicillin allergy have been shown to have a 3-fold increased risk of allergic reaction compared to people who aren't penicillin allergic, even non-related drugs, which have nothing to do with penicillin or cephalosporin or beta-lactams. People always used to say that 10% of patients with a penicillin allergy will have a cephalosporin allergy. And that data may not be accurate. There may have been some contamination of the cephalosporins with penicillin-like material. So we're going to explore this concept for just a few minutes. This information is reproduced in your notes. And what I'm showing you here are, again, here's the penicillin species over here. Here's a cephalosporin species over here. You can see the same beta-lactam structure on a 6-member ring. This is the side group on penicillins, and you can see different penicillins have all sorts of complicated side groups, from something relatively simple like penicillin G, which just has this methyl group followed by an aromatic ring, ampicillin, which is slightly more complicated, and you can see why there might be some cross-reactivity between a penicillin allergy and an ampicillin, or even an amoxicillin allergy. But certainly, antibiotics can get quite more complicated, all the way up to something like piperacillin or ticracillin, which have very different side chains. There are actually 3 side chains on a cephalosporin, R1, R2, and R3. This table just looks at R1 and R2. And at first glance, we can see some things look a lot like penicillin. So here's cephalexin, which is Keflex, and its R1 side chain is very much like ampicillin's side chain. And it turns out that most people, when they are allergic, are not allergic to the beta-lactam. They're allergic to the side chain. And so you wouldn't be surprised if I told you that cefazolin, which has a very different side chain than cephalexin, has a different profile of allergic reaction. And while we expect a crossover between ampicillin and Keflex, a cross-reaction between ampicillin and Kefzol is a lot less likely. This table looks at different side chains at the 7 position, side chains at the 3 position, and different columns show drugs that are similar to each other. So here we see cefoxitin similar to penicillin G at the 7 position, but Keflex is not similar to penicillin G at the 3 position. And by analyzing this data, we can start to find groups of drugs that are likely to cross-react and certain drugs that are unlikely to cross-react with any other drug. And this is one of the reasons why Kefzol is considered such a ideal drug, because it really doesn't have a lot of cross-reaction with other beta-lactams. You can spend more time on this information yourself, but that's all I want to say about it for now. So to summarize, not all cephalosporins are the same. There are people who think that Keflex and Kefzol are the same drug, just one is oral and one is IV, and we just saw that that is absolutely not true. And so therefore, whether a patient had an allergic reaction or not to Keflex is pretty much meaningless when we're deciding if they can have Kefzol. And any patient who had a minor penicillin allergy, like a rash or a fever, should probably be just fine to get a cephalosporin in the operating room. What if the patient had an anaphylactic reaction to penicillin? Well, there are people who are allergic to the beta-lactam species and not the side chain, and for that reason, we usually avoid cephalosporins in patients who have a penicillin anaphylaxis. And that's appropriate in the absence of any quantitative allergic testing. We're going to speak about a couple other cell wall type medications. The next one is vancomycin, which also inhibits cell wall synthesis. It works mostly against gram-positive bacteria, and it is the treatment of choice currently for MRSA, the methicillin-resistant Staph aureus. Now, if you swab somebody's nose or a wound for bacteria and they grow out Staph aureus, and you look at the sensitivities to see what antibiotics it's sensitive to, because you want to see if it's methicillin-resistant or not, you often might not see methicillin even shown on the list of antibiotics, and what you usually want to look for is oxacillin. So actually we call it MRSA, but we're really looking for ORSA, oxacillin-resistant Staph aureus. So patients who are resistant to oxacillin and other advanced cephalosporins should get vancomycin instead. Patients who have methicillin-susceptible or oxacillin-susceptible Staph aureus should be fine with a cephalosporin like cefazolin. Patients who have renal disease can have vancomycin accumulate in their bodies, and so you have to modify dosing, and sometimes we even check a vancomycin serum level. Otherwise, it's just redosed every 12 hours. Vancomycin can be given orally. It isn't really absorbed into the body very well, but it's a good treatment for C. diff colitis. Common adverse reactions of vancomycin include fever and chills, irritation at the IV site, and toxicity to the ear and occasionally to the kidneys. Many people are on the lookout for red man syndrome, where patients do actually become very red in their skin. And this is due to that non-immune mediated histamine release that we've discussed. And it can be largely avoided if the drug is given slowly over the course of an hour. As it's given faster, patients will develop red skin, itching, and hypotension. Daptomycin is a good drug for vancomycin-resistant bacteria, really working primarily against gram-positive bacteria. I usually give it just as a slow bolus, and at our institution we're using it for neurosurgical cases where we're having a lot of issues with surgical site infection. It's an expensive drug and not a routine prophylactic medication. Finally, carbapenems, like meropenem or imipenem, are also beta-lactams. They work primarily against gram-negative bacteria, anaerobic bacteria, and Pseudomonas. And they seem to have a lower risk of allergy in patients who have a penicillin allergy. And so if they have a rash or something like that, it would be safe to give a carbapenem, just like a cephalosporin. So that's a lot to cover. That's really just the cell wall, cell membrane antibiotics. And in the next section, we will discuss the rest of the antibiotics.